A record 33,000 delegates from all over the globe converged on the Excel Centre in the capital's Docklands to hear international experts present the latest science, clinical studies and new treatments in the world of cardiology. Despite improvements in mortality and morbidity, cardiovascular disease still remains the main killer in Europe. The 5-day meeting was packed with presentations to further improve management and treatment. Among all the latest technologies, devices and therapies showcased at the meeting, it was actually an old drug, spironolactone, that stole the show.
The session that was of the greatest interest for me was the Hotline 4 session, which covered Pathway 2 and Pathway 3, which are two British Hypertension Society, British Heart Foundation studies, and they're both positive results. And probably the most exciting thing that's happened at the conference so far. But we're going back in time because they're both studies in old treatments. Pathway 2 is a study looking at the best way to treat resistant hypertension, and in essence they were looking at spironolactone versus an alpha blocker versus a beta blocker, and spironolactone was the clear victor. This trial will change guidelines, certainly change the European Society of Cardiology guidelines. It reinforces the NICE guidelines, and one of the things suggested by Brian Williams, who presented it, was that we now have to redefine resistant hypertension, and the discussant, Professor Mancia, agreed with that, that the definition now would include resistance following the use of spironolactone. And then the other trial was the Pathway 3 trial, which again was going back to old treatments, and that was looking at the effect of amiloride versus hydrochlorothiazide versus a combination of those two drugs, and the effect it would have on the glucose tolerance test. And in essence, the hypothesis was that amiloride would be neutral in its effect, and it was, and hydrochlorothiazide would be negative in its effect, and it was, and the combination was actually worked quite well. So again, we're going back to old drugs and reinforcing many people's views on what should and shouldn't be used in hypertension.
Cardiovascular disease is popularly believed to be a man's disease, and a major focus of the meeting was to right this misconception. Many sessions highlighted its incidence in women who now face a higher risk of heart disease than men in Europe.
I'm sure you will all put your hand on your heart and say that you will do absolutely no difference in the way you treat women or men with ischemic heart disease in particular, but there are here a number of presentations that highlight the fact that this is not the case. There is still a perception that cardiovascular disease is a male disease rather than a disease affecting women, and it's true that the absolute numbers of women affected may be lower, but yet women still die of cardiovascular disease in great proportion. In fact, in about 50% of all-cause death for women is cardiovascular disease. So what are the issues? The issues are related to presentations. Presentation of cardiac disease in women may differ from men, and therefore it may be misinterpreted or misdiagnosed. There are interesting interactions between diseases that are common in women, such as connective tissue diseases, inflammatory diseases, radiotherapy for breast cancer, and development, say, of coronary artery disease. And this may not always be at the forefront of a normal, everyday jobbing cardiologist that is more used to see the classic presentation of ischemic heart disease. Yet, we know that primary and secondary prevention and any other intervention that is guideline-based is as effective in women as it is in men. So why this is not apply, it remains perhaps at the present a mystery. What it is not a mystery, although, are the consequences. And there is particularly notable a registry that was presented here, the data from a registry of out-of-hospital cardiac death from France, that shows a much higher proportion of women died of cardiac arrest, and also a lower proportion of women offer angioplasty, even though there was absolutely no doubt that according to the guidelines they should have had it. So is this an issue regarding women only, or is it maybe an issue that is related to age? Women tend to present when they're older, so is this a feature of ageism, if you like, or is it because of comorbidity or any other issues that are not strictly related to sex, but are a corollary of the complexity of cardiac disease in women? In any case, these are issues that need to be resolved, and resolved soon. They are a priority of the European Society of Cardiology. They are a priority of the American Heart Association and the NIH. So we can't ignore them.